Hello everyone. Here in this short video, we are going to learn the layers of scalp, different layers of scalp and its clinical significance. So the scalp, by definition, this is the soft tissue covering the cranial vault. And this soft tissue, which is extending anteriorly from the superciliary arch backwards till the external occipital protuberance and the superior nuchal line behind. And on either side, if we trace the scalp, it will be extending up to the superior temporal line. So the soft tissue part bounded or lying within this specified area we will call as the scalp. In this video, we are learning what are the different layers and how to learn the clinical significance of each layer. So the 5 layers of the scalp can be named as follows. The first layer of the scalp is skin, and the second layer followed by the connective tissue layer, or otherwise called as dense connective tissue layer. And the third layer is musculoaponeurotics, that is called as gallia aponeurotica or aponeurotic layer or epicranial aponeurosis. And the fourth layer, that is called as loose areolar tissue layer. Further, the deepest layer, that is the pericranium, this is the 5th layer. So now let us explain each layer in detail. So the first layer of the scalp, that is the skin. Skin of the scalp is very peculiar. That's not similar to the skin of other parts of the body. So the first thing, the skin of the scalp is comparatively very thick, and it is with abundant hair or hair follicles, and these hair we are usually calling as scalp hairs. Additionally, the skin of the scalp will show plenty of sweat glands, sebaceous glands, and this is richly vascular. This rich vascularity is an advantage because any injury happened to the scalp, that will be healing quite quickly. It won't take much time to heal. So that's why most of the time plastic surgery is related to the scalp or the face, that will be giving good result in short span of time. And the skin, because of abundant amount of sebaceous gland, clinically sebaceous cyst is quite common in case of scalp, and it will be extremely painful. Usually thick skin we can appreciate in the palm and the sole, which is non-hairy. But the skin of the scalp is an exception. This is thicker but hairy. Let us skip to the next layer, that's the second layer. This is the layer which is just deep to the skin. This is called as connective tissue layer, or otherwise called as dense connective tissue layer, because the components are densely or compactly arranged in this layer. And this layer consists of fibrofatty tissue, and in this fibrofatty tissue, embedded in this fibrofatty tissue, we have plenty of blood vessels like arteries and veins, and also subcutaneous nerves are there. And there is a peculiarity, these vessel walls, the wall of the blood vessels in this second layer, these walls are very adherent to the fibrous tissue of the second layer itself. So what is wrong with that? So because of this, any injury happened to the scalp means, so the bleeding will be profuse, because that retraction of the blood vessel itself may not happen. But usually injury happened in some other body parts means the vascular retraction will be happening. This is not happening in case of scalp. That's why there is a tendency for the profuse bleeding. So that we have to remember. The second layer of the scalp. Next is third layer. This is called as epicranial aponeurosis, otherwise called as gallia aponeurotica or aponeurotic layer. So this layer consists of muscles and aponeurosis. There are 2 muscles. Anteriorly one muscle is there called as frontalis, and further posteriorly there is another muscle called as occipitalis. And both these frontalis and occipitalis, these 2 muscles are inserted to an aponeurosis in the middle part. This is called as gallia aponeurotica, otherwise called as epicranial aponeurosis. This layer is very important because there are peculiarities for these muscles also. Anteriorly, the frontalis muscle, this is so special because this is a muscle which is devoid of bony origin. This is arising from the skin of the forehead just at the area of the superciliary arch, and further the fibers are traveling backwards and upwards in order to get inserted to this epicranial aponeurosis. And posteriorly there is another muscle called as the occipitalis. These muscles are arising from the superior nuchal line, and further these fibers are directed upwards and forwards in order to get inserted to the gallia aponeurotica. And this gallia aponeurotica or epicranial aponeurosis, this is the third layer lying between these two muscle fibers, and laterally if you trace it, it will continue as a very thin membrane that will be continuing over the temporal fascia in order to get attached to the zygomatic arch. So that's about the third layer, gallia aponeurotica. Now its clinical significance, if injury happened to the scalp, if the injury or the cut is transverse or anteroposteriorly, so that we have to go through. If the injury is happening transversely, means there is a chance of profuse bleeding, because there will be a pull by the frontalis forwards and the occipitalis backwards. So that's why the bleeding will be profuse and the gapping will be more if the cut injury is transverse. But if it is extending anteroposteriorly, so the gapping will be minimal, and we can apply pressure in order to reduce the bleeding. Next to the aponeurotic layer, we will enter to the fourth layer. So this is called as loose areolar layer. As the name suggests you, loose areolar means, so this layer is with abundant loose areolar tissue, and this layer will be showing rich number of veins. These are plexus of emissary veins. We know the emissary veins are connecting the extracranial veins with the intracranial dural venous sinuses. So these veins are the direct communication between emissary veins are the direct communication between the intracranial dural venous sinuses and extracranial venous channels. So because of this direct communication, the fourth layer is popularly called as the dangerous layer of the scalp. Why is it called as dangerous layer? So the fourth layer is lying just beneath the aponeurosis. So just beneath the aponeurotic layer, any infection happen means we will call as subaponeurotic layer. Such infections can spread very quickly to the cranial cavity, and that can cause intracranial infections, meningitis or encephalitis. So that's why, because of quick spreading of this infection through the emissary veins, so this layer is popularly called as the dangerous layer of the scalp. So this you can expect as an MCQ for various competitive exams. And another clinical significance related to the fourth layer, so that is formation of black eye because of injury or trauma related to the skull region. Sometimes there will be a blackish discoloration and swelling on the periorbital region. So there is an anatomical reason for that, because already we have seen that the frontalis muscle that doesn't have the bony origin, that is arising from the skin. And because of extravasation of bleeding at the subaponeurotic layer or the fourth layer, what is happening due to gravity, gradually that blood can come and settle surrounding the orbit and the upper eyelid. So that will be resulting in a discoloration, blackish discoloration surrounding the orbit, the periorbital region, because there is a direct communicative space, both fourth layer and this periorbital space and upper eyelid. So that's the anatomical basis for the formation of black eye. This is very important clinical significance related to the fourth layer or loose areolar layer. Next, another important factor related to the fourth layer is safety valve hematoma, especially in infants and newborns. So sometimes in children, what is happening, in case of fracture of the skull bones, so there is a chance of epidural hemorrhage. And this epidural hemorrhage, that blood may come through this emissary foramen through this fourth layer to this fourth layer, and this blood will be initially filling in this fourth layer, and after filling this fourth layer, then only that blood will be having a tendency to compress the brain or the parts of the brain to form the hematoma. After filling the fourth layer only, this hematoma formation within the cranial cavity will happen. So that's why this mechanism is popularly called as safety valve hematoma. So next, let us enter to the deepest layer, that is the fifth layer called as pericranium. This is nothing but the periosteum of the skull bones of this related area. And this periosteum, which is made up of the connective tissue, so that will be covering and that will be adherent to the cranial vault, and then further that will be passing through the foramina, emissary foramina. That will be very adherent to the sutural ligaments of the neighboring area. So that's about the pericranium. After passing through the emissary foramen, that will be continuing as the endosteal layer of the meninges, that is the dura mater. So that's about the pericranium. So these are the relevant points related to the 5 layers of the scalp. Thank you.